Dear colleagues, congenital hip dislocation is one of the most important and challenging topics in pediatric orthopedics. In our research, we are evaluating the conventional treatment of hip dislocation in order to find the most personalized treatment protocol. My name is Gyula Domos. I work as a pediatric orthopedic surgeon at Semmelweis University. My vision is to ensure the highest quality treatment for our pediatric patients and to build one of the best pediatric orthopedic centers in Europe in 10-15 years. In order to achieve this aim, we have to introduce and follow the best available treatment methods in every field of pediatric orthopedics, and we also have to work out new treatment protocols. My current research fits well into this concept. In the first part, we are investigating the risk factors of failure in the treatment of congenital hip dislocation. Based on a systematic review and meta-analysis, we would like to reevaluate the conventional treatment of hip dislocation and to define how we can reach the best results and avoid complications. In the second part, we are analyzing the results of our treatment protocol at Semmelweis University, which is different from the international protocol, but we seem to have better results and less complications with that. Because of the large number of publications and the high amount of data, we divided the first project into 3 topics according to the different treatment steps. So now we have 4 ongoing projects. The first 3 projects are about the risk factors of failure in the hip dislocation treatment. I started to write the first publication in the close reduction topic in May, and I'm planning to finish it in September. The target journal is the Bone and Joint Journal with 5 impact factors. Let's see how the 3 projects join each other. According to the international protocol, after a failed conservative treatment with public harness, or in case of late diagnosis, a close reduction of the dislocated femoral head is performed under general anesthesia. If the close reduction fails, an open surgical reduction is needed. If the open reduction fails too, additional surgery, femoral and/or pelvic osteotomy is performed. But complications with this treatment protocol are quite common. Unsuccessful reduction and redislocation are the main reasons for failure. In addition, the most serious complication, the avascular necrosis of the femoral head, is common too. The overall rate of it is 10% in closed and 20% in open reduction. What we don't know exactly is the overall rate and the risk factors of failure. But if we could identify the cases where the conservative treatment will probably fail, we could skip the conservative step in the treatment and we could perform a close reduction immediately. Thereby, we could avoid several complications and unnecessary interventions. If we could select the cases where the close reduction is likely to fail, we could skip the close reduction step and we could perform an open reduction immediately. And based on this scheme, we could perform a complex surgery immediately if an open reduction will probably fail. So our questions are, what are the risk factors and the overall rate of failure in the treatment of congenital hip dislocation? We are investigating 3 groups, children with conservative treatment, with close reduction, and with open reduction. The intervention is the presence of risk factors and the comparison is the absence of risk factors. The outcome is the rate of failure in the subgroups. Our hypothesis is that certain risk factors increase the rate of failure in the treatment of hip dislocation. I performed a systematic search in October in 3 databases. My search key was about hip dislocation and reduction. Altogether, I found more than 12,000 records and more than 200 eligible full texts were selected. These publications covered the 3 topics, the conservative treatment, the closed and the open reduction. Regarding the risk factors, we found 78 publications and we found 132 other publications only with data about the failure rate. After we decided to divide the study into 3 topics, I performed a systematic search regarding the close reduction again and found 107 eligible full texts in this topic. In the close reduction group, we found data about 5 different types of failure. The primary failure rate is 13%. This group consists of two subgroups. The intraoperative failure is when the dislocated hip is not reusable under anesthesia in the operating room and an open surgical reduction is performed. The rate of it is 25%. The postoperative failure is when only the postoperative CT or MRI scan shows that the first reduction attempt was not successful. The rate of it is 5%. After a primary successful reduction, redislocation can also occur. The rate of it is 8%. And the rate of the overall failure is 20%. Regarding the risk factors, we found significant results. The grade of dislocation significantly influences the failure rate. In low dislocations, the failure rate was significantly lower, but in high dislocations, the failure rate was significantly higher, both in X-ray and ultrasound classifications. And we also found another important result. The failure rate was significantly higher in preoperatively irreducible dislocations compared to reusable dislocations, and in male patients compared to female patients. There are several strengths of our study. This is the first systematic review regarding the risk factors of failure. This is the most comprehensive meta-analysis in the topic of hip dislocation treatment, and we were able to identify high-risk patient groups. But there are some limitations too. Publications do not consistently investigate and define the different failure groups, and the treatment protocol was not exactly the same in all institutions. The conclusion of our study is that the risk of failure in closed reduction is high in case of high dislocations and preoperatively irreducible dislocations and in males. In these high-risk patient groups, open reduction is advised instead of closed reduction to avoid complications, but randomized clinical trials could clarify what other factors influence the risk of failure in these patients. In the open reduction group, we have found less data about the failure rate. The postoperative failure rate is similar to the closed reduction group, 4%, and the redislocation rate is also similar, 7%. But the overall failure was significantly lower than in closed reduction group, it was 10%. During the data extraction, we realized that we have to investigate the fourth topic of hip dislocation treatment, the open reduction with osteotomy group, to get the intraoperative failure rate. During full text selection, we found 143 eligible full text, which we are analyzing now. We found only a few risk factors in this group, and we didn't find any significant result. That is why we are going to investigate this group with the open reduction and osteotomy group together. Regarding the conservative treatment, the rate of failed reduction is 11%, and we are working on the potential risk factors. In the fourth project, we are analyzing the data of our patients with congenital hip dislocation treated with primary complex surgery. At Semmelweis University, we don't use the international protocol in the treatment of hip dislocation after a failed conservative treatment or in case of late diagnosis because of the high rate of failure and avascular necrosis. During the treatment, we would like to avoid the forced reduction of the dislocated femoral head because it can damage the blood supply and can cause avascular necrosis. As we cannot select the cases where the conventional treatment will probably fail and then avascular necrosis will develop, we skip the closed and open reduction step after a failed conservative treatment or in case of late diagnosis, and we perform a complex surgery with open reduction, shortening femoral osteotomy, and joint reconstruction. Although we perform more surgeries than the other centers, but practically we can minimize the rate of failure and avascular necrosis. In this project, we are investigating the exact rate of complications and the late results of the treatment. So these are the topics we are investigating this year. After finishing the publication about the topic of closed reduction, the next step is the open reduction, then the conservative treatment group. After completing these three topics, we are planning to finish the analysis of our own results. I brought a quote from István Szepsi, who is a famous and internationally recognized winemaker. His verse that the highest qualities are a moral duty is a very important role also in medicine, especially when we treat children. Thank you for your attention.